Okay, well, good morning, everyone. My name is Tami Singleton. I am a pediatric hematologist and technically oncologist by education and training. For many years now, I've had an opportunity to serve in the bleeding and clotting disorders community, um, serving both children and adults. And it is always a pleasure to have an opportunity to speak to you guys here in your meeting. We're going to talk this morning. I'm going to present some concepts about, first, just a little bit about research, and then I'll explain to you a little bit about rare coagulation disorders and how we use ATHN systems. So just a little bit about me to put this in context. I am the Chief Science Officer for the American Thrombosis and Hemostasis Network. In addition to that, I am also the co-director of the Hemostasis and Thrombosis program at the Oxnard Clinic Foundation, which is located in New Orleans. It's actually the largest healthcare provider in the Gulf South. And we will soon have our first class with the Xavier Oxnard College of Medicine. I've been with ATHN about 3 years now as the Chief Science Officer, but I have worked as a principal investigator with ATHN almost since its inception in 2006. So ATHN, just to give you a little bullet about what ATHN is, the American Thrombosis and Hemostasis Network is a non-for-profit organization that was actually formed and established by doctors and people serving in the bleeding disorders community in 2006. There was a bit of a call to action to ensure that we had a way to protect safety surveillance in the hemophilia community and the bleeding disorders community. There was a call to action to ensure that we had ways for observational studies and maybe even ultimately interventional studies specifically in the bleeding disorders community, thus the name, the American Thrombosis and Hemostasis Network. Every HTC in the country is an ATHN affiliate. So we form the ATHN affiliate network. There are also HTCs that are not necessarily federally funded, but are providing services to the community, actively serving, wanting to be engaged in this community, that are also a part of the ATHN affiliate network, so that we can have an opportunity to ensure that surveillance and safety is also offered to those of you who may not have an opportunity for one reason or the other to be seen at a federally funded hemophilia treatment center. Currently, there are about 156 hemophilia treatment centers that are a part of the ATHN network and one international site. So let me tell you just a little bit more about research studies just to lay the foundation. So there are two big groups of clinical trials. There are clinical trials, and I'm going to take this off here first. Yeah. So there are clinical trials that are interventional studies. And interventional studies are studies, we're all familiar with this concept. Interventional studies are studies where something is being studied as a potential therapeutic option. So there's an intervention with a medication. We're reviewing the efficacy and the safety of that product in various stages, phases, to intervene options, again, therapeutic options, surgical options, but observational studies are a little different. Observational studies are different in that we want to see and understand what is happening when we refer to something as from a natural history standpoint. We want to know what happens and what is actually happening in almost a real world setting with whatever treatment you're receiving, a specific treatment that you're receiving, how is that treatment being dosed, what is happening from a safety standpoint. And that information can be very valuable to serve as a foundation moving forward for interventional studies to say that a lot of those studies are necessary. So we've already reviewed a little bit of this, and I'm going to sort of dive into the three big things that ATHN does, just to explain. Because some of you may have heard of the Community Counts program, and when I was here last year, I spoke a little bit, was that last year or year before last? I kind of lose track of time. That was last year, right? That was last year. We talked a little bit about the community counts program because we had concerns about funding and what was going to happen with data, what was going to happen with that surveillance program. Well, Athens serves as the facilitator of the community counts program. That is just one of the things that we do from a public health standpoint, interacting and supporting all of our hemophilia treatment centers from a surveillance standpoint, with that being funded by the government. In addition to that, we support all of the hemophilia treatment centers just in their sort of in their alliance and their government and the way that they work. We serve as the hub where everyone can gather, talk, have meetings, um, and sort of march on one accord from a hemophilia treatment standpoint. We also, as the third prong of this sort of like a three-prong stool, we also provide opportunities for people living with bleeding and clotting disorders and um, principal investigators serving at each hemophilia treatment center to facilitate or participate in research, primarily observational research. Again, what's happening from a safety standpoint? What's happening from an efficacy standpoint in many of the treatments that have previously been approved, so that we can have power and understanding of how those things continue to work in the community and what happens, again, especially from a safety standpoint. So those are the sort of three big prong areas. And in addition to that, the fourth thing I think I should include would be we have partners from a community standpoint with all of the advocacy organizations. So we're not, as ATHN, we're not a patient-facing organization. We're facing and working with the HTCs to serve you, but we partner, thus me being here, we partner with advocacy organizations, education organizations such as CHESS. One of the things that was established by ATHN in roughly 2009 was something called the ATHN dataset. So when you are a patient or someone living with a bleeding or clotting disorder and you are seen at a hemophilia treatment center, your treater, your hematologist, your team may approach you and ask if you would like to participate in submitting your data in an anonymous way that can be used from an observational standpoint to understand what's happening with people living with bleeding and clotting disorders. Currently, there are over 71,000 different participants in the ATHN dataset that covers almost every bleeding and clotting disorder that we see or treat here in the country. And that health information is, again, helping us to gain a better understanding of blood disorders, clotting disorders, bleeding disorders. Investigators from each treatment center, if they have specific questions, meaningful scientific questions that they want to ask, learn more about factor VII deficiency, learn more about Glanzmann's, learn more about fibrinogen deficiency, congenital TTP, in addition to what's happening maybe with women and girls, intracranial hemorrhage and hemophilia. They can write a study and say that they want to participate in an observational study with ATHN and have access to some of that data ultimately, and the hope always is that it will be something very meaningful to contribute to the community. ATHN 10 was a program that included the ATHN dataset, which included what we refer to as phenotypic data. What is happening when someone has a bleeding episode? What is happening when someone needs a treatment, either because you're only treating a bleed or you're using a treatment to prevent a bleeding episode? So all of the data on participants in the ATHN data set that we refer to again as that phenotypic data, what happens when you bleed, we wanted to combine that information with genetic testing because often there's a significant discrepancy between the diagnosis of a rare bleeding disorder and what actually happens from even a factor activity standpoint or a bleeding standpoint. Does that sort of make sense why we wanted to combine those two things to ask that question? Well, ATHN, as a non-for-profit organization with all of the hemophilia treatment centers, provided the platform for participants to use the data from the ATHN data set. And CIBD in Southern California with Dr. Diane Nugent, they used or provided a way for us to have genetic testing that could complement that phenotypic data. So we would have an opportunity to learn more about how patients bleed, what products they were using, and did that correlate with factor activity levels, and did it also correlate with genetic mutations that were detected or picked up by Dr. Nugent's lab, CIBD. Does that kind of make sense? Perfect. To participate in that program, you have to provide your consent, right? You have to say, I want to participate in ATHN10. I want to participate in the ATHN data set. And then those samples from a genetic standpoint, once you said, I agree to have my blood drawn for genetic testing, Dr. Nugent's lab then ran those samples. Some of those samples, it was very interesting, were very consistent with what we expected with the diagnosis at hand. Some of those samples had results that were not consistent with the condition at hand and actually revealed either another condition, a secondary condition, or maybe even what we refer to as a variant of unknown significance. We're not quite sure what that mutation meant. But there's a lot of information that has come from the ATHN10 program. And again, at the ATHN10 program was ATHN contributing data from the ATHN dataset, and CIBD, the lab, contributing data from the genetic testing. The genetic lab at CIBD is a CLIA certified laboratory that any physician can send a genetic sample to. In the ATHN10 program, we were specifically looking at a list of diagnoses and wanted to look at those to see what the genetic variants may have been related to those and provide data from the ATHN dataset. So again, these are just the steps. When you participated in ATHN10, what happened along the way? The ATHN10 program has formally come to an end, but ATHN and the ATHN dataset has not come to an end. CIBD as a laboratory that performs genetic testing has not come to an end, and we are continuing the partnership, offering participants at a hemophilia treatment center an opportunity to participate in the ATHN dataset. And at those HTCs, you can also submit a genetic sample to CIBD. But it does not fall under the formal umbrella of the ATHN10 program. If a hemophilia treatment center has any questions about how to submit samples to CIBD, to that laboratory, ATHN can provide some support and instructions on how that can happen. CIBD will also be the primary source of interacting with any hemophilia treatment center that has any questions as to how to submit a sample to CIBD. Dr. Nugent's lab will continue to provide that genetic testing with no charge, hoping that participants in the ATHN dataset will be those that are asking for the genetic testing so that we can have access to, within the hemophilia treatment center community, important information about how you're bleeding, how you're being treated, and the genetic variant, so that Rare Coagulation Disorder Initiative will continue, but just not under the formal umbrella of the ATHN dataset. I'm sorry, of ATHN10. It will be the ATHN dataset and samples submitted to CIBD. So again, the initiatives have not discontinued, they just continue in a different way. So we've learned very valuable information with the ATHN10 program. A lot of the samples that have been collected over the past year and a half are actually still being processed with the ATHN10 program. So although the formal ATHN10 program has come to an end, We will be working collectively with CIBD over the next year, maybe even year and a half, to make sure that all of those samples are completed with that laboratory and that they are then connected and reported back to the HTCs of the physicians who submitted those samples. Currently, just a little information about what we've learned thus far and the reason why we want to continue to learn this information. We found over 176 new genes that have been added to our data to facilitate a better understanding. Some of this Dr. Nugent and her group has reported on or published on. Again, this can help us as a community to better understand, diagnose, and maybe even manage rare bleeding disorders. We're adding awareness through this project. So it was incredibly important to the community that this opportunity and that this effort not end, but we want to ensure that it continues. We want to ensure that it continues. We want to ensure that we continue to publish our findings, because it's also important that we not only bring awareness, but that we have additional funding to continue to bring awareness to the things that are needed for the community and our efforts to ask these questions. So again, CIBD offers and will continue to offer the complementary genetic testing services that has broken down barriers, I think, over the past few years of people living in the community, so that access remains. If you have a question at your hemophilia treatment center about the testing that is offered by CIBD, again, your HTC can ask CIBD any questions about the requisition, how those samples can be submitted, and ATHN is also on standby to ask and support the Hemophilia Treatment Center in directing them in terms of how do you submit those samples, where do you find the requisition form if they don't have the requisition form. It is basically the same way that it was previously submitted, with a few changes. Okay. So again, the center of what we're looking for is real world outcomes, like what is actually happening. Some of those real world outcomes will contribute meaningful information for things that we don't really have a lot of information about. So some of the ultra rare coagulation disorders, we still need to have natural history information in terms of exactly how people are bleeding and what you're facing. We also need to know how some of those conditions are being treated when there are not specific therapeutic options that may be available for some of the ultra rare conditions. So by combining the information from a bleeding phenotype, how it's happening with the ATHN data set, and the opportunity to have genetic testing with CIBD, we will continue to have a very robust database and infrastructure for future research, how to ask, learning how to ask even more meaningful questions, and finding those very directed and targeted answers. In terms of what can you do, if you have any questions about how you can have a genetic sample sent or analyzed by the CIBD laboratory, it would be one of the hemophilia treatment centers across the country that could answer that question for you. And again, ATHN is on standby to support that center in making sure that you have the answers to that question. So I'll take questions, right, about the Rare Coagulation Disorders Initiative.
Morning. Thank you for the presentation.
Thank you. Good morning.
I am Canadian. I participated in that Athens or that first study. I think it was Athens 10.
Athens 10.
With Dr. Nugent. Am I eligible to continue with CIBD? How does that work? Do I need to get my own hemophilia treatment center to get involved? Because I didn't last time.
So if you were a participant in Athens 10, that means that you should be enrolled in the ATHN dataset, as well as you should have had a sample submitted to CIBD, a blood sample. You would need to speak to your HTC if you haven't seen the results of those samples or that sample to determine what is the status of that sample. One of the things that I think is probably pretty important to note is the samples are batched together. Remember, this is a complementary effort that they're providing us. So it can take, on an average, anywhere from 9 to 12 months before the samples may be batched. It just depends on when you were drawn and where it may fall. After they're batched and run and the results are available, it takes a little time with the ATHN program to put those results like into ATHN system so they're made available to your treatment team at your hemophilia treatment center. So if you've already participated, you're done. Like that's done, right? That sample has been run, it's done. You just need to have an opportunity to ask what is the status of it so that you can then sit down and review the results with your center. Yep. Oh, yes. No, no, no. So no, there's no second step. I think her question was a very valuable one kind of for clarification. So again, the ATHN program has formally come to an end, but we are continuing the exact same effort we're calling it the Rare Coagulation Disorders Initiative. So it's not ending, so it's not something different or new.
So the demographic and medical history information that we completed, what will that be used for?
The demographic and medical history information? Yes. So the demographic and medical history information is incredibly important when we talk about bleeding phenotype. So it's really important if we're looking at how you're bleeding and looking at what your diagnosis is, what your factor levels are, what the discrepancy may be with that, to determine are you male, are you female, are you 50, are you 10? Because we can see differences from a bleeding standpoint in different age groups and maybe even in different ethnicities. So that information is really important. Your medical history is incredibly important because other comorbidities, what you are also experiencing, may also be incredibly important. If there's another bleeding disorder, that's important. If there's another clotting disorder, that's important. If you have a history of hypertension and may be predisposed to clotting, that's important. So we use all of that information in very specific ways to ensure that we can have real answers. When I kept saying natural history, it's that part. Like from a natural history standpoint, to understand the full picture of what's happening when you're someone living with a bleeding or clotting disorder. It's also important to note that that information is anonymized. So you can't be identified as an individual. And there are significant restrictions on how we can use the information and what anyone can see. Can't see your state, can't see, your specific area. But sometimes there are questions that are important because access to care is also something that's incredibly important. So if you're someone and you're on a state Medicaid program, are you having the same access to care as someone with private insurance and vice versa? So we also answer some of those questions. So all of that information that's collected is incredibly valuable. And I'll tell you too that sometimes some of the physician scientists, and me included, we're really digging in and trying to ask very meaningful questions. And many times, all of the information that we have, with all the information that we have at ATHN, we still want more. Like we're still asking more questions, right? Well, do you have any quality of life measures? Like what else do you have? Because we really want to make sure that this data is very robust so that we can actually use it to make meaningful changes within the community. Okay. Who's next?
Hello. So let's say that we had a participant who submitted their blood in the beginning of the study, and then we have people at the end of the study. Is that data being rerun to look at the other variants that were found throughout the study?
So I'm going to try to flip that, to think what I think you're asking. And with the disclaimer, I'm not a geneticist, but I think I do okay. Yeah, I'm a geneticist. I think I do okay. So, there are various things that can happen when you have a genetic sample that's submitted. So again, you can have a variant that is detected that is consistent with what has been previously known. We expect to see this for the diagnosis of record. You could also have a variant that is unknown. We pick up a variant, we're looking at that and going, haven't seen that before. We've actually published on this with ATHN that there's a variant, and we've seen that variant not before, but because of ATHN, we've seen it now 19 different times. And so it seems to be really consistent with, let's say, for factor 7 deficiency. So now we can use that information and go through the very rigorous process of saying this genetic variant is consistent with people living with factor 7 deficiency. And I'm going to add how cool this is. And with some of the ATHN phenotypic data from a bleeding standpoint, we can also tell you how these patients are bleeding, what their factor activity levels are. Is it consistent? So very powerful information. There may also be variants of unknown significance that we don't necessarily see a correlation to, and those will continue to be followed and evaluated almost to the end of time. We're going to continue to use those because as we collect other samples and see other people, we want to have that same process. We want to have an opportunity to have that variant be identified, hopefully as being consistent with something. So the data will continue to be sort of analyzed and used if there's not a specific answer. And moving forward, I don't know, if something weird happened and there was something else that was consistent with one of the variants, and we have a whole list of those, we could go back and say, hey, yes, there is something new that's associated with that. I hope I answered that in a way that you could understand. Okay, I'm following my instructions over here.
No, thank you so much for like explaining that because that was part of my question as well. Um, I wasn't aware that I guess I did do the Athens 10, including my daughter. I had no idea. But we came here to this trip to try to get tested, but I guess we're already tested. But right before this trip, like a couple days before, I had a telehealth with Nina Wong at CIBD, and she went over a lot of stuff that I do not understand with all the genetic testing that they did on my daughter. Like what you had said, the significant, I forgot what you had said, and I'm like, oh my God, is this like something that we need to worry about? Like, who else can we ask in terms of like those results of those tests? Because like whatever they told me, it just like went over my head. Do we need to sit down with the geneticist or what's the next step to know? And like I had brought my mom with me to get tested, and you said there's no more Athens test. Athen 10, but we could still go to the CIBD. Is there any way she could get tested? Because I feel whatever my daughter has, it has to come from our family. So my mom has to have something too. So who can we ask, especially since I go to CIBD, so they could like run a test on my mom or something to know more information. And then the Athens people or the genetic people can get more information.
Okay, so I'm gonna try to tackle the first part, the first part of your question. Um, so I think it's incredibly important, and we probably should have done a better job of talking about this even last year, I think. Our we called it our one drop initiative. I think it was great. I'm super proud of what we did together, because I think it really serves as an example of what can be done in the community. But I think we sort of forgot one really important step, and that is before you have genetic testing, or if you're going to consider genetic testing, you really should consider having a sit down with a genetic counselor. Um, you should have a conversation with your hematologist for sure. Like that's a given, right? Have a conversation with your hematologist. But in addition to that, have a conversation with a genetic counselor. And let me step out of this and just provide you sort of with a tangible example from a personal standpoint. Right now, like with a condition I have, a condition my husband has. I have a friend who also has another cardiac condition. We're talking, right, about what are the best therapeutic options for different things? What doctors should you see? And I went, I think you really need to stop and sit down to have a conversation with genetics to try to understand, is there any direction that you could have or any information that you could gain that would be valuable in determining how to move forward from a treatment standpoint or surveillance standpoint based on any genetic mutation that may be there. You may also have a conversation with a genetic counselor and determine that you don't want to have genetic testing, like at this time, right? I thought I wanted to have it, but once we talked, I think I'm going to wait. Or I wanted to have it, I think we're going to have it, and then this is what I can expect. So I think that we had a little bit of a fumble in not explaining, I think, the importance, right, of having a conversation with a genetic counselor. Your primary care doctor can direct you to a genetic counselor. Your HTC can direct you to a genetic counselor. You can direct yourself, right, to a genetic counselor. So seeing someone in genetics is something that's fairly easy to do, whether you need to have a referral, they're in your hemophilia treatment center, or you do it on your own. It's important, I think, to have that. But again, it's also very important to have a conversation with your doctor, your treatment center, about what your questions are, right? And I'm going to say something I said yesterday. Communication is key. It's incredibly important. Just because, and I was picking on married people because I'm married, right? So we have a conversation, and just because words came out of my mouth and words came out of his mouth doesn't mean, right? Doesn't mean that like, it doesn't mean that there was true communication, right? So in that effort, even when you're talking to your doctor, like we're very well-meaning people, typically, like we want to serve. We did all this because we want to, we want to help and we want to do right. But sometimes you have to give people grace, give yourself some grace, too, and go, okay, maybe I just need to re-communicate that. I also think that communicating in different ways can be incredibly helpful. So write it down. Write it down for yourself and then read it. Write it down, put it in a portal, write it down, send it email, fax. Like sometimes trying to communicate in different ways can really help in terms of what some of your questions are and what you would ultimately like to accomplish, right? So when you don't understand something, it is so important that you do understand it. And if someone is explaining it to you and you're not understanding the words that are coming out of their mouth, ask someone else. But don't give up on trying to understand it. But with genetics, genetic counselors, genetic teams, they're fantastic with explaining things so that you can understand it. But then you also, in an ideal world, want to make that connection with your hematologist to put everything in perspective. And the final thing about understanding genetics, if you don't understand it the first time, that's okay. Again, give yourself some grace. It's okay. That's right. Yeah. It's it's okay. Yeah, it is okay. You might not understand it the second time. It may take, two or three or four different times and someone to break it down in a way that you can understand. Um, we have so many things available to us electronically. I think I made the joke and comment yesterday that anybody over the age of 8 that has two nickels to rub together, I know you have a phone, right? And on that phone, you are Googling and doing all types of things. So trying to find tools electronically that can just break something down in a way that you can understand it. I would slap, people on the wrist all the time. Don't tell me you looked up something on Google. Yeah, but but it can be a very valuable tool just to break down some concepts. So give yourself some grace. is a very valuable tool. So we have a lot of things, right, available to us. You can break it down in different languages. You can say, explain it to me like a 2-year-old. Like there's so many things that you can do. Now, your second question is incredibly important because that's the core of what I'm trying to address here. CIBD has an amazing genetics laboratory, and they're offering an amazing service to this community. Talk to your hematologist and ask them when you go in, if you have not had genetic testing with CIBD, can I have it? Can you help me? Oh, no, I don't. And if they don't know, can you please try to find out for me? Like, how can it be available? Because you can have genetic testing at Mayo Clinic, Arab, laboratories, GeneDx. I can go on and on. Like the number of laboratories that technically you can submit a sample to. CIBD is just one of those labs. It's a certified laboratory that anyone can submit a sample to. It just so happens that CIBD is extending an amazing service to people in the coagulation disorders community, and you can have a sample submitted from your HTC. They just need to figure out how. And you can even include, ATHN can provide some support in how it happens after ATHN 10. We're going to keep talking about it with the treatment centers and providing information, but that's the way that you get it done. Okay, I think I did okay in answering that. I was worried about my brain remembering all that. Yeah. Absolutely. I haven't had my 3 shots of espresso yet.
Hello. I apologize. I missed some of your talk. I
That's
had
okay.
my daughter.
That's okay.
So if you answer this already.
Yeah, it's okay.
One, when my daughter had her ATHN 10 done months ago, she had a much different bleeding pattern. She was not infusing. How do we update that so ATHN has the most up-to-date information on her and her condition?
I love these questions. I absolutely love these questions. So,
I have another one too.
Oh yeah, go for it. Yeah, go for it.
So we haven't gotten our Athens yet, but her doctor sent her to genetics at our university's hospital, and she came back with a variant of uncertain significance found in her factor 10.
Mm-hmm.
How do we find out if someone is doing research to give a name to that or find out what that means?
Yep, love that question too. So, when you are a participant in the ATHN data set, you've given your permission, you say, hey, yes, I would like my information with how I'm being treated, how I bleed, like all of that information. That's the information that we're using. When you say I'm a participant in the ATHN data set, you're like, you have my permission to do that. When you come in each year, every 6 months, that information is entered into ATHN systems. And so over time, that will be seen. If it was entered in 2021, we'll see it. 2022, we'll see it. 2025, we'll see it. In addition to your genetic testing from another place could also be entered into ATHN systems with your other labs, so that at some point moving forward with our Rare Coagulation Disorders Initiative, when Dr. Nugent and her team and our teams and the interested doctors across the country, when we're pulling this information, we'll see that variant of unknown significance. We'll see the change in the bleeding pattern because that information will be requested and pulled into, anonymously, pulled into to ATHN systems in the ATHN data set. Yep. So 156 hemophilia treatment centers across the country participate in as an ATHN affiliate. So if you're seen at a hemophilia treatment center, they have access to the ATHN data set. Yale participates
No,
in the ATHN data set.
Okay.
They may not have participated in ATHN 10. Not every site did.
Okay.
But Yale participates in the ATHN data set.
Okay.
Yeah. So you absolutely can ask to be a part of the ATHN data set. And again, all of that information, this is key because this is exactly how the program is supposed to work, right? The program works because we pull your information into the ATHN data set. That information over time, that medical history that she asked about before, demographics that she asked about before, your laboratory results, like your factor levels, your genetic testing, all of those things are incredibly important to answer meaningful questions. So for sure, the ATHN data set is available at that site.
Okay.
Got one back there and then.
I have a question. I have been told my HTC does not do any collection or draws for Athens at all. And I'm at Northwestern in Chicago. Where would I go? And also, if I went to somebody else, would this be automatically covered, or would it be covered by Medicaid and Medicare? Just trying to figure out how this works, because I know from many other people who wanted to be a part of it, they were told, we're not doing it.
So I want to try to, again, backtrack and clarify. ATHN has the ATHN data set, but we also have other research programs and other research studies. ATHN 10 was one of those other research studies. ATHN also has research studies. ATHN Transcends, ATHN 16, we've had ATHN 9, but the ATHN data set is a registry kind of monitoring and taking in information from a real world standpoint. So if someone said to you, we're not participating in ATHN, what does that mean? Every site is participating with ATHN, but they may not have participated in ATHN 10. They may not have participated in ATHN Transcends. So this is specifically the ATHN data set registry. Like this is not another study. This is not a study like ATHN 10. It is the ATHN data set registry. CIBD is a laboratory that is certified and approved in the United States, just like LabCorp, Arup, Mayo Clinic, GeneDx. Again, any lab that you could mention that is certified and approved to run samples in the United States, CIBD is also one of those labs. If your site in your hospital doesn't have a partnership to send labs to a specific laboratory, you can ask that they do. Like, what does it take? So if your doctor wanted to send a sample to Mayo Clinic and that hospital didn't have an account with Mayo Clinic, they can get one. It's not prohibitive. CIBD offers genetic testing to people in the community from HTCs with support, so that testing is complementary.
We have a question on Zoom. How is ATHN 10 changing the landscape for previously thought to be benign variants and reclassifying them to VUS? And is there any literature coming out to redirect previously educated genetic counselors and physicians to move past the previously thought benign variants and to have those providers reconsider that VUS does not mean benign by default?
So CIBD has used some, or is working to use some of the information with variants of unknown significance, as well as with new variants to move forward. It's a very complicated process. Whoever asked that question sounds like they have something to do with genetics. Maybe. Do you? Maybe. So we're, so we're working through that process. So there is a publication, there's an abstract that we submitted to ASH that is available. So you can pull it up about the new variants that we just recently published on. Dr. Nugent led that effort in her laboratory, Dr. Williams in that laboratory, they led that effort. All of the other variants of unknown or uncertain significance, there is absolutely an intention to go through the process to ensure that they will ultimately be recognized, but you're probably familiar with the fact that it's a complicated and kind of long process, but it's also important because it can be population based. So your contribution is important. So when you participate in the ATHN data set, and when we have these genetic variants that are available to us, instead of going through that process in that committee with 2 people or with 2 variants, we can go to that process with 20, like with some of the information to back up to support it. So yes, that process is happening. We right now only have abstracts that have been published, but papers are on the way. And we will continue to do that. Oh, and yes, for those of you that are here, we do have an abstract that is on the back wall that, by the way, was us describing the details of the collection and the effort that we put together here with this organization, which to my knowledge was one of the first, is the first of its kind quite like that in this effort in the rare coagulation disorders community. And we fully intend to continue to publish on information like that so that we can show the power that's associated with advocacy, the power that's associated with participation, and the power that's associated with support.
Let's say
And
you
it's being presented at WFH in Malaysia, by the way. Yeah.
let's say you aren't seen at a hemophilia treatment center, but your provider is interested in getting you enrolled in an ATHN program. How would your provider go about maybe like partnering with an HTC
Yeah, sure.
provider?
The path of least resistance in that is you can still see your provider, but go to the HTC to be enrolled in the ATHN data set. Like that's the path of least resistance, like because that's already set up. It can be very complicated to become an ATHN affiliate, there's a very complicated process that you have to go through with the entity, with ATHN, so it can take some time. If you are, though, an entity that is not a hemophilia treatment center and you're seeing a relatively large number of patients in the coagulation disorders community, there are physicians, treaters, that ultimately want to be investigators, and they will ask and say, hey, can we become a part of the ATHN affiliate network? Because we have patients that are at our center and they want to contribute their data to the ATHN data set, and we would like to participate. And ATHN, I think, is very interested in that. I fully support that because we want to know what's happening with there's an estimated 30% of people that are not seen at a hemophilia treatment center. And those numbers are larger when you're talking about ultra rare conditions, so that we can have this cohesive, right, collective effort. You guys are probably getting this right now, like the power in the numbers, like the power when we're working together, like the information that we have. Like one center is one thing, but when we have multiple centers across the country and a lot of information, that brings power to science. And from an evidence-based standpoint, we can make real change. So again, path of least resistance would be go to the hemophilia treatment center that's near you and say, hey, listen, I'm in the coagulation disorders community. Here are my records. I would like to be seen here, but primarily because I want to participate in the ATHN data set, but I'm going to keep my doctor, in the community.
I've enjoyed it listening to you, and I've got a couple questions. I'm trying to keep it real simple here,
Sure.
but ATHN is just a data center. You collect data. When you had Athens 10, somebody drew blood samples and did research on that blood.
Sort of. You're almost there. Yeah, almost there. I'll explain it in a minute.
Yeah, and so my question then is, if somebody wants to have their blood drawn to find out if they know they have factor 7, but maybe they have factor 10, or maybe they have factor 13 in addition, how would they get that blood drawn at their HTC and then sent somewhere so the research can be done to find that answer?
Okay, so let me try to answer the first question and I'll tackle the second one. So ATHN is a non-for-profit organization serving only the bleeding disorders community, right? Serving this community. And yes, is data collected by ATHN? Absolutely. Data is collected primarily with the ATHN data set. But data is also collected for different reasons. We wear different hats. So ATHN is the one center for data, but ATHN serves different purposes and different roles, right? ATHN serves as the platform for the surveillance program for community counts, which has nothing to do with any research, right? That's safety and surveillance. So that's one, all walled off by itself. Technically, and I go back and forth with people about this all the time, but the definition of research is collecting information so that you can provide change and answers, like period. You can call it observational research. You can call it interventional research. And even if you are not doing anything but observing it, looking at it, looking through it, it's still technically research. So that's what we're all doing and interested in. In collecting the data with the ATHN data set, we're looking at all of the information that happens to you with your factor 10 deficiency, your factor 13 deficiency. Does your activity level really correlate with the way that you're bleeding? With someone who has a factor level of 13% bleed like someone who has a factor level of 20%? And do you have the same genetic variant? By asking those questions and trying to provide those answers for change, like technically that's like observational research. And that's what we're doing, like with the ATHN data set. When CIBD provided a way for you to submit a sample, technically that sample was not going to a research laboratory. That sample is going to a genetics laboratory, like almost any genetics laboratory. So you can submit a sample to CIBD, maybe even for something else, because it's a real genetics laboratory, and pay whatever the fee is associated with having that run. That same thing can be done from a genetics standpoint at, again, any other genetics laboratory, like in the country. So it's not a research lab, but we are actually conducting research by observing the lab that has been done, if that makes sense, right? It's not a research question with that lab itself, right? Because any doctor can send a sample to CIBD for genetic testing. It's not a research laboratory. So moving forward, understanding how there may be any differences with activity levels, or how or if there are any differences with genetic variants or mutations, that's exactly what we're trying to answer, but answer cohesively and collectively within ATHN systems, so that doctors from any HTC can say, hey, ATHN, I have this question about factor 10 deficiency. And what are the mutations that have been seen in patients that have had genetic testing sent, and how are they bleeding, and what are the factor levels? How does this correlate? Does that kind of make sense? Yeah.
And then the next question is, you made the statement that you may not want to do genetic testing.
Yeah.
And I'm sitting here trying to say, well, why
not?
But I have an example is in the area that I live in, they have a thing called the Princeton Longevity Center. And they'll give you a full body scan and tell everything that's wrong with you and potentially what may be coming down the pike. And I said to myself, there's no way I'd be doing that.
Right. I don't want it either.
Is genetic testing something similar to that?
That's correct.
Okay.
Yeah. Again, I can give you like even a personal example. I personally don't want a test that you can't do anything about, and I'm not willing to do anything about it. And I've refused testing over time for myself personally. I'll ask them, like, what is that? And what is that for? I don't need that information. Do you need and I'll ask. I'm trying to be cooperative with my physicians, right? Like, do you need the information for anything in particular that I'm not aware of that you need to do? Opening the door, like, to have the conversation so that you can explain. Because if you want me to do something, like, I'm not, like, that's not an option. So that's what so it's like that. I don't ever want a full body scan. Because there are some things I'm just not willing. I'm not gonna do that. Like, yeah, I don't know. You tell me I have to cut off my pinky toe, I'm not gonna do it. Yeah.
Yes, ma'am. Quick question. Is the VA system involved in,
Oh, HTCs? No.
no, not HTCs,
Oh.
like for like the veteran hospital systems? Is that involved in that?
Involved in ATHN or any of this stuff? No. There are I'm going through my Rolodex. Like I'm standing here, right, thinking. There are no VA hospitals that are directly involved. At hemophilia treatment centers, though, we do serve and service veterans, right, and plenty of them. But no, there are no hemophilia treatment centers and no studies where we're actively involved, like with the VA system.
So you mentioned that, was it 30% of the patients enrolled in the ATHN data set are not seen at an HTC?
No.
Was that the number? What was
No,
the
that's
number?
not quite right. So there is an estimate that 30% of people living with coagulation disorders, especially hemophilia, are not seen at hemophilia treatment centers.
So do we know why?
I'm sure that there are multiple reasons why. Up into and including, a lot of us have a choice of where we go and who we see. I actually have a choice. I learned this one of the most valuable lessons I ever learned. You know, as a very young doctor, I don't have to see you. If it's an abusive relationship, like I don't have to see you. If you don't have trust or confidence in me, you don't have to see, you don't have to see me. It can start with that. It just may be, it's also resource driven, a lot. Like it's super hard to drive an hour or 2 hours or maybe even 3 hours if a center is not located close to you. So that's probably the most common reason. If there's a treatment center, it's just not convenient, like to get there and go. And I really consider that to be like a barrier. There are not a lot of us, so you don't have a lot of choices. So, again, if there's a confidence issue,
Well, I
you
think
may
that there
choose to
may
see
be
someone
that,
else, but you may have a choice. You have a choice often in who you see. So it can be any number of reasons. With people with ultra rare coagulation disorders, people are actually not even aware that there are hemophilia treatment centers and coagulation specialists. Like they're seeing a GYN, they're seeing the local hematologist. You don't even know. So there's so many different reasons why. So again, in reverse, what that means is typically the data that you see that ATHN has, that we have an estimate that covers 70% of the population, but there's a hole of 25 to 30% of people that are not included in that, which is why it's important, I think, I really support this initiative, that if there is a non-HTC that wants to participate, like with the ATHN data set, that we welcome that because we also want to have that information.
I think that that's really,
Okay. Yes. So the question was, how many of you know that you're being treated or seen like at a federally funded hemophilia treatment center? I know I spend a lot of time actually explaining to my colleagues what a hemophilia treatment center is and how it serves the community, both patients and providers, like the service that we provide. If you have questions, if you have complicated patients that you're seeing, how we can support you. A lot of people don't know. So it's so many different reasons why people are not seen at a federally funded hemophilia treatment center. We actually want to know some of the barriers so we can work through, trying to make that better.
well, and the reason why I brought up that point was, like in the spirit of continuous improvement, maybe that's something that would be really amazing to get more data on. Why do people go to an HTC? Why don't they? Why do they go to a private hematologist? Why don't they? And I think like really getting more data, because I think the more information that we have, the more that we can strive for continuous improvement and understanding. And I think a lot of the, I think we all want that physician that wants to learn, because a lot of people do not contain, they just don't have the knowledge of the ultra rares. And it's definitely been a pain point in my life. And I'm sure it's been, I've heard lots of stories of it being really difficult for other people as well. And, I want a doctor that just says, I don't know. I need to
So
learn.
so I think you're bringing up a good point. I don't know if you're not purposely doing it, but I'm gonna voluntold you. Like, so as in many of the organizations that I'm in, I'm voluntold, to do something. So lived experience experts, like when you have a meaningful question and you want to participate in research questions, like what's happening, you actually do have an opportunity. There are opportunities to do that. And so I think that that's a very powerful and meaningful question. And you should, really hold on to that. And there are ways that you can work with investigators to push that initiative along as well from a community standpoint. I think that you're really onto something there. And that's a question that we want to see answered at ATHN, which is why we open the door in terms of other centers if they want to participate.
Like, so from my experience, I choose a private hematologist and I do go to an HTC on an emergency basis and to do clinical trials, because I think that data really matters.
Right. But again, to that point, like what we're talking about, like power is in the numbers, right?
It is.
So asking those questions, meaningful questions, and knowing like why that 25 to 30%, some of I think it's a very powerful question to ask. We're time? 5 minutes?
10,
Oh, okay. 10 minutes? Okay.
Could you explain what a VUS is?
Yeah.
And then I'm wondering, as time goes on, if the classification of something that's called a VUS changes,
Yeah.
do you let our hematologists know?
Yeah. So when you have a change in your DNA or in a gene, and we have found a variant. Let's say, DNA is made up of building blocks called amino acids, and the amino acids are supposed to say CTGAU. And instead of saying CTGAU, it says UTCAG. And so it's changed, right? And now, like, the whole messenger RNA can't come along and read it and produce the protein. That change is called a variant. At some point, no one knew what the variant meant, but at some point, someone took the time to say, hey, this variant is associated with many people that have this condition. We have a process through something called ClinVar and many other steps, actually, where in the United States, we say, oh, there's a scientist, physician scientist, that has found a variant and says it's consistent with all of these people that have this condition. And then that is then proven ultimately to say, okay, this variant is associated with hemophilia. This variant is associated with factor 10 deficiency. This variant is associated with factor 7 deficiency. So there's a process that has to go through. The power to me in this type of initiative is if there's a variant of unknown significance over here, and one that's over here, and one that's over there, and there are 5 or 6 of them that we know of. Just from a logistical standpoint, it may be challenging to go through and collect that and find that. But when you have an initiative and there are larger numbers of people that are presenting with these variants of unknown or uncertain significance, that means that we see the variant, but we don't know for sure. It hasn't been demonstrated or proven to be associated with this specific condition, but we think it is. Then we have an opportunity to go through that process to say, yes, this is associated with this. And we've actually done some of that with this ATHN 10 initiative. It's just that variants that have been seen, we have to go through the process. Dr. Nugent's lab and the amazing people with CIBD, they have to go through that process to say, yes, this is now proven, and we can say, and it's published. So any doctor, any scientist, any person will have access to variants that are associated with it because that information will be known. So she's asking, do we let the hematologist know if something has changed, or do they find out on their own? No, kind of as hematologists, it's our responsibility to continue to be, kind of educated and sort of in the know. There's no one who's, knocking at our door to tell us that something has changed, but that's our responsibility in a process. So when we're going to congresses and reading and participating in efforts, we continue to learn and understand when something new has changed.
We have time for two. We have two back here, and then we're going to be all done.
Hi, I have a question. Do you know if Texas Children's is in your program?
Yes.
They are. And do you recommend, we have two kids affected by factor VII, that the parents test also, like all four of us? Or we've done genetic testing, and so we know we each carry a different mutated gene. One is supposed to be worse than the other, but I don't know, like, if we need to go further.
When you say you need to go further, you just said that you have done genetic testing already?
Just a baseline, like we did it when our daughter was diagnosed with factor VII. She has factor VII and von Willebrand, and then I have von Willebrand. And so we were trying to understand where it came from because no one else in our family has had issues with bleeding.
Yeah.
For the factor VII portion. So
to answer the first question that you said, and I think there's a second question there I'm going to tease out. So the first question is, if any additional testing should be done, is there anything else that should be explored here? To me, if you haven't sat down with genetics and a genetic counselor, that's the perfect place, I think, to try to explore some of those deeper questions of what should happen next in conjunction with your hematologist. Typically, if there was a variant that has been identified, the variant has been identified, you have it, that information is there. But if you have a question in terms of, with any new technology, is there anything else that you think that we should do? That's definitely, I would talk to your hematologist about wanting to have that done and wanting to have that conversation. But I really think that that's a conversation you should take to someone specifically with genetics, right?
So we did see the genetic counselor as part of like their annual workup. We see them each year, and they weren't able to go into great detail. They were just like, you have it. We don't know why this doesn't show up on the test. It is what it is. Like, I don't know if she was uneducated about this particular disorder.
So when you say you have it, but we don't know and we're unable to see it on the test,
like
that sounds like that's a question you have to connect that back to your hematologist. So if they're meaning that we see a variant, but your factor VII levels don't indicate, that you have a deficiency, but we see the mutation, those are the ongoing questions that are super important that you take back to your hematologist.
Okay, and so we can do it with Texas Children's then and just start there again.
So you can do any genetic testing with Texas Children's. You can participate in the ATHN dataset with Texas Children's. And if you have not had genetic testing at all, I would say that, yeah, you can even ask that you have genetic testing done with CIBD. But I don't know that it would be valuable, worth your time or the resources at all to have the genetic testing repeated and just repeated at CIBD.
Okay.
But I think it's really important, going back to what we were saying before, you don't necessarily process or understand everything the first time you hear something. Actually, there are those theories you have to hear it 7 times, right? Before you can really kind of process something. So I think going back and forth with your genetic counselor, but communicating with your hematologist. So I would expect that a genetic counselor is not going to, or even a geneticist, a PhD, is not going to know all the details of factor VII deficiency, right? But I do. And so they know more information about the genetic mutation, the process, like the testing, what's available, and then we connect that and marry that and put that in concert with the information that's coming from your hematologist. And with that, I think you can really have the best of both worlds, but you have to have an ongoing conversation, because I think it's really important that if you have something that's inherited, that you have some understanding of how it happens. So a genetic mutation started with somebody. So whether the somebody was you, the somebody was the child, the somebody was your great grandmother 3 times removed, it started with somebody. And if it needs to be present with 2 genes to present itself versus 1, then that's something that you have to understand too. So many of us may carry something, but we're not manifesting the condition because you have to have 2 of them. And so then understanding that one came from you, the other one came from him, and now the offspring have the condition. So whatever the circumstances, that's what genetics and a conversation with genetics, along with a continual conversation with your hematologist, can help you to piece together that story so that you understand it. But I promise you, like when we say, I don't know, where did this come from? Oh, it came from it did come from somewhere, but if you were the somewhere, like the mutation started with you, or if the mutation started somewhere else, right? So if you could imagine genes are formed, the chances that a mistake might be made or something flipped, like with a gene with the hundreds of thousands that we may have, so something may happen in producing proteins, like that's possible. And it's not always documented unless you're from a royal bloodline.
Okay. One more small question. They only did genetic testing for factor 7 specifically. So would this Athens test be beneficial? Does it test for more than just factor 7?
Oh, that's a really good question. Okay. So yes.
Okay. That's what thank you.
That's a good question. Yeah.
All right. I would like everybody to thank Dr. Singleton. Okay.